Hi, everybody. Welcome to our presentation. We will be talking about types of anemias and their corresponding disease managements. My name is Angela Corgi.
My name is Justina Corgi.
And my name is Myrna Salomon.
So the objective of today's presentation is that oftentimes anemia is categorized under one common assumption. Usually people associate anemia with just iron deficiency, but this is untrue, and anemia is actually an umbrella term for a multitude of different types of anemias. In this presentation, we aim to spread awareness of these different types of anemias while also informing our audience of their possible disease managements.
So first, we're going to give a brief background on blood. Our blood is comprised of two sections, the plasma and the formed elements. The plasma is the liquid portion, which is made up from mostly water, but contains proteins to aid in transportation and blood clotting. The plasma also occupies 46% to 63% of the blood. The formed elements are made up of red blood cells, white blood cells, and cell fragments called platelets. Red blood cells, also known as erythrocytes, are the most abundant formed element, making up 99.9%. Hemoglobin, the protein responsible for gas transport, is the most abundant protein within the red blood cells, making up 30% of the mass of the cell. There's millions and millions of copies of hemoglobin inside of every single red blood cell. More specifically, hemoglobin is a globular protein made up of 4 protein subunits or chains made from globin genes. In adults, there are 2 alpha chains and 2 beta chains. In children, there are 2 alpha chains and 2 gamma chains. Embedded within the center of each of the chains is a functional group called heme. Heme groups contain iron, which binds to oxygen and allows it to be transported within red blood cells. Because there are a lot of hemoglobin in red blood cells, and each hemoglobin contains 4 heme groups, there is a really high capacity for gas transport in the blood.
So what exactly is anemia? Anemia is defined as the situation in which one lacks enough normal erythrocytes. This jeopardizes the blood's ability to carry oxygen from the lungs to the body tissues. Due to the blood's composition, it is susceptible to mutations, meaning that these mutations can alter our normal blood. There are a multitude of ways that our blood can be mutated and therefore affect the ability of proteins to transport gas or the stability of that protein. This can ultimately lead to the demise of that cell. Anemia can also be temporary or long-term, and cases in its severity ultimately vary based on which type of mutation is present.
So here we can discuss the very simple blood tests that can be used to determine anemia. One very basic test that can detect anemia is known as the hematocrit. This test determines the percentage of red blood cells that occupy a blood sample that contains red blood cells, plasma, and the buffy coat, which is made up of white blood cells and platelets. Essentially, it is a ratio of red blood cells versus the plasma along with the buffy coat elements. Another basic test, known as the complete blood count (CBC), can take the blood and determine the mean corpuscular volume, known as MCV. The MCV is the average volume of red blood cells in a sample and helps indicate what type of anemia is present.
As said before, there are many types of anemia. Listed on the slide is a brief overview on how each anemia is subcategorized. So first we have microcytic anemia and its 2 subcategories known as thalassemia and iron deficiency. Next there is macrocytic, and one of its subcategories is megaloblastic anemia, which can be further subcategorized into pernicious anemia. Then we have normocytic and its 4 different subcategories: anemia of chronic disease, aplastic anemia, post-hemorrhagic anemia, and hemolytic anemia. We also have polycythemia, and finally sickle cell disease, also known as sickle cell anemia, but we'll get into that later on.
Now more on microcytic anemia. Microcytic anemia is characterized by the abnormally smaller red blood cells. When in comparison to normal blood cells, they have a decreased red pigment along with a smaller overall size. It is often indicated by its low mean corpuscular volume, which happens to be lower than 80 cubic micrometers. The most common types of microcytic anemia are thalassemia and iron deficiency.
All right, so first off, we have thalassemia. Thalassemia is a type of microcytic anemia. Anytime you have a mutation in the DNA cells that make up hemoglobin, that is usually referred to as thalassemia. Specifically, thalassemia occurs due to abnormalities in the synthesis of the globular chains that attach to heme to make hemoglobin. There are two types of thalassemia, alpha thalassemia and beta thalassemia. Alpha thalassemia occurs because of gene depletion. One type of gene depletion is 3-gene depletion, where beta chains start making tetrameres in the absence of alpha chains. Symptoms are apparent after birth. Another type of gene depletion is 4-gene depletion, where tetrameres are formed by gamma chains because of the absence of alpha chains. As a result, the fetus dies in the utero. Beta thalassemia, however, occurs due to gene mutation. Minor beta thalassemia is mild and asymptomatic. Major beta thalassemia is normal in a fetus but results in severe anemia after birth. In severe cases, thalassemia can cause bone deformities, causing the bone marrow to expand and the bones to widen. Expansion of the bone marrow can also thin and brittle, leading to an increased chance of broken bones. Thalassemia also causes abnormalities of the spleen, which aid in fighting infection within the body and filtering unwanted material such as old or damaged blood cells. As a result, because of the increased red blood cells, the spleen begins to work harder and is therefore enlarged. Other complications include slowed growth rates, delaying child's growth, and puberty. Congestive heart failure and abnormal heart rhythms can also occur. All right, so we have the symptoms and disease management. So here are the signs and symptoms of thalassemia. A few include fatigue, weakness, facial bone deformity, slow growth. Also, some newborns may show symptoms of thalassemia at birth, while others develop signs during the first 2 years of life. Patients with only one affected hemoglobin gene do not experience any of these symptoms. There is no prevention for this disease. Some treatments can include blood transfusions for those who have severe forms of thalassemia, and although it works well, it cannot be used as long-term therapy treatment because of potential iron overload. This could potentially damage heart, liver, and other organs. We also have cleaton therapy, which is another treatment method that removes excess iron from the blood, which may or may not have resulted from iron buildup from transfusions. Oral medications such as deficiency or an injected drug can help eliminate this iron. This can help eliminate this excess iron. Another method includes stem cell transplant. These procedures involve an anemic patient receiving infusions of stem cells from compatible blood donors. For children with severe thalassemia, this treatment method may eliminate the need for blood transfusions and iron-depleting drugs.
Sorry about that, I forgot to unmute myself. But iron deficiency can also lead to microcytic anemia. As mentioned before, within hemoglobin, at the center of every heme group is an iron molecule, and when there is a lack of this iron, there is a reduction in the size of red blood cells. The lack of iron can result from a number of things. Sorry, did not mean to press that. The first cause is decreased iron intake. Humans must obtain iron from their diets, and when not enough iron-containing foods are obtained, iron deficiency will result. As for infants who are younger than 6 months of age, the absence of iron in breast milk can lead to iron deficiencies. Next is an increased iron demand in the body. This type of iron deficiency is caused by an increase in blood volume and the demand for the body to produce more hemoglobin. This occurs during rapid growth of children and adolescents, as well as in pregnant women. Decrease in iron absorption can also lead to iron deficiency. Stomach acids in the small intestines take part in the release and absorption of iron from food. Reduced absorption occurs from gastrectomy, and or diseases of the small intestine, which will lead to this iron deficiency. Lastly, blood loss is a leading cause of iron deficiency. For those with female genitalia, heavy menstruation causes this blood loss. For those with male genitalia, blood loss is commonly due to peptic ulcer disease, which is when open sores or ulcers develop on the lining of the stomach or the duodenum of the small intestine. In elderly patients, colon cancer can also cause blood loss and therefore lead to iron deficiency. On to symptoms and disease management. Some symptoms include extreme fatigue, chest pain, cold hands, unusual cravings, poor appetite, and the risk of iron deficiency can be produced by choosing iron-rich foods. Foods rich in iron include red meat, beans, dried fruit, etc. Other food containing vitamin C to enhance iron absorption are also good food choices. And for treatments, taking iron tablets on an empty stomach. If causes upset stomach, take with meals. Do not take antacids, as these medications can interfere with iron absorptions. If antacids are needed to relieve heartburn symptoms, take iron supplements 2 hours prior or 4 hours after. Take iron tablets with vitamin C, as it improves iron absorption.
Now on to microcytic anemia. Microcytic and macrocytic anemia is characterized by abnormally large blood cells. Macrocytic red blood cells are characterized by vitamin deficiencies. Macrocytic anemias contain Megaloblastic, which is caused by deficiency of vitamin B12 and folate, and non-megaloblastic anemias, which is caused by alcoholism, liver disease, drugs, and reticulocytosis. In this presentation, we will mainly focus on the megaloblastic anemias, including pernicious anemia. The typical MCV for macrocyte exceeds 96 micrometers cubed.
All right. Megaloblastic anemia. Megaloblastic anemia is the most common type of macrocytic anemia, in which the megaloblasts, or abnormally large and immature red blood cells, are produced in the bone marrow. The most common causes are deficiencies in essential vitamins B12 and folate. That results from poor absorption or improper utilization through the body. Poor diet intake of these vitamins are also a contributing factor, though deficiency of this is not severely related to this condition. The characteristics specifically found only in forms of anemia caused by this deficiency in vitamin B12 and folate are distinguished by obtaining an MCV greater than 100 micrometers cubed, as well as hypersegmented neutrophils and megaloblastic changes in the rapidly dividing cells. All right, on to some symptoms. Affected patients with this condition may go years as asymptomatic through common symptoms that may include fatigue, paleness, lightheadedness, muscle weakness, loss of appetite. Prompt treatment is required in deficiencies in order to prevent neurological symptoms. Some forms of these treatments include dietary supplements like folate and vitamin B12 that can be administered orally or intravenously. In severe anemia cases, blood transfusions might also be beneficial.
All right, so a subcategory of megaloblastic anemia is known as pernicious anemia or vitamin B12 deficiency. Vitamin B12 deficiency mainly occurs in essential areas of the body, particularly in the bone marrow. Insufficient levels of this water-soluble vitamin leads to negative effects on erythropoiesis, causing greater malfunctions in the production of red blood cells. This disruption in erythropoiesis induces defective synthesis of DNA, resulting in anemia. Pernicious anemia is an autoimmune disease in which a reduced production of intrinsic factor, also known as type A gastritis, and hydrochloric acid are caused by the destruction of parietal stomach cells. This gastric atrophy of both intrinsic factor and hydrochloric acid are essential in the absorption of vitamin B12, thus failure of this absorption leads to deficiency. Other causes not related to pernicious anemia include defective absorption of vitamin B12 in the ileum, such as Crohn's, celiac disease, resection, surgery, intestinal bacterial growth, and fish tapeworm, as this is where vitamin B12 is stored. Pancreatic insufficiency is another cause, as the pancreatic enzymes are also essential in the freeing of vitamin B12. A vitamin B12 deficiency can be depicted by low levels of hemoglobin combined with macrocytosis and hyperchromasia. All cells affected by vitamin B12 deficiency also portray a decreased level of thrombocytes and leukocytes. The symptoms of pernicious anemia includes usual symptoms of anemia such as lethargy and paleness in the skin and mucosa, as well as a weakness, fatigue, tachycardia, and jaundice. The treatment of this deficiency usually begins through elevated doses of hydrocobalamin, 1,000 micrograms to be specific, administered parenterally, until values of vitamin B12 are normal or progressing. Every 6 months afterwards, it is recommended for patients to receive this dose.
Next is normocytic anemia, which is characterized by normal-sized red blood cells. However, the red blood cell production is not happening at a quick enough rate. Other reasons for this anemias are due to an increased destruction of the red blood cells, a greater volume of plasma, or a mix of both microcytic and macrocytic anemia. To identify this anemia, we see a normal MCV, but in a hematocrit, the hemoglobin is at a much lower level. The most common forms of normocytic anemias include anemia of chronic disease, aplastic anemia, post-hemorrhagic anemia, and hemolytic anemia.
All right, so first up we have anemia of chronic disease. The most common type of normocytic anemia is known as anemia of chronic disease. It's characterized by the low levels of red blood cells along with a low MCV, which then leads to an autoimmune disease, where the body's immune system will attack its bodily organs or joints, or chronic illness. Another name for this anemia is known as anemia of inflammation. Some of the chronic disorders associated with this anemia include inflammatory conditions, infections, neoplasms, and various systemic diseases. This anemia is due to changes of red blood cells that are caused by different chronic diseases. These changes will inevitably cause red blood cells to die sooner and also decrease their production. People are likely to develop this anemia in the chronic inflammatory state, as the liver produces a protein known as hepcidin. This will cause iron absorption to cease in the duodenum, ultimately preventing iron from being recycled. Another factor leading to this anemia is the impairment of iron's metabolism within the cells. So on to symptoms and disease treatments. Some signs and symptoms include feeling fatigued, shortness of breath, feeling dizzy, rapid heartbeat. For disease management, in the case of anemia of chronic disease, it is treated in a very specifically oriented way. The underlying disease that is creating the anemia is the first thing that needs to be treated. In many ways, treating this disease portion itself will reduce a multitude of symptoms and resolve the anemia almost altogether. However, this might not work for all anemias that are caused by cancer or chronic kidney diseases. Therefore, more in-depth and specialized treatments are available to those patients. Blood transfusions, again, are another form of treatment for those who have very serious anemias. The last treatment available is a synthetic form of erythropoietin, which is dispensed as a shot to those with low EPO levels.
Next is aplastic anemia, which is a type of normocytic anemia. It is a rare, life-threatening condition as a result of the body's failure to produce new blood cells. Although this anemia presents an absence of any abnormal cells, such as leukemia or dysplastic cells, it is instead characterized by pancytopenia, a condition where an individual has low counts of all three blood cell types, and hypocellularity of the bone marrow. This further expresses damage and intrinsic defects in the hematopoietic stem cells. Stem cells present in the bone marrow produce three cell lines: white blood cells, red blood cells, and platelets. Since the stem cells are damaged in this type of anemia, the bone marrow portrays emptiness. Aplastic anemia can be either acquired or inherited, mild or severe, and can develop at any age. Inherited causes of aplastic anemia include the intrinsic defects in the hematopoietic stem cells, which are immature cells that develops into a red blood cell, as well as other disorders such as Fanconi anemia or Down syndrome. In acquired aplastic anemia, the causes range from a series of conditions. For example, radiation and chemotherapy destroy healthy stem cells in the bone marrow. Autoimmune disorders or pregnancy damage healthy cells by one's own immune system, and exposures to toxic chemicals or medications such as benzene or antihistamines. The bone marrow cellularity is less than 25% as mentioned before, and the blood of aplastic anemia lacks in white blood cells, red blood cells, and platelets, which is also known as pancytopenia. It's a tongue twister. And on to the slides. The symptoms, my bad. People with POTS. And now on to the symptoms and disease management of aplastic anemia. People with aplastic anemia can be asymptomatic. However, common symptoms of aplastic anemia can include pale skin, fatigue, prolonged bleeding, shortness of breath, etc. Though there is no prevention for aplastic anemia, avoiding exposures to toxic chemicals may decrease risks, as well as terminating exposure to radiation and chemotherapy treatments. After diagnosis through blood tests or bone marrow biopsy, treatment can include blood transfusions, stem cell transplant or bone marrow transplant, bone marrow stimulants, immunosuppressants, and antibiotics or antiviral medications. A stem cell or bone marrow transplant is the treatment of choice for those younger in age or have a sibling and accepted as a candidate for transplantation. Healthy stem cells are injected into the bone marrow in order to start producing new blood cells. Bone marrow stimulants also aid in prompting the formation of new blood cells. Those with acquired aplastic anemia, such as autoimmune conditions, are not suitable for transplantations. Therefore, immunosuppressants such as cyclosporin seize the activity of immune cells from destroying the bone marrow in order for recovered bone marrow and new cell production too.
Acute post-hemorrhagic anemia, also known as acute blood loss anemia, is another form of normocytic anemia. The cause of this condition is due to a loss of a large amount of blood, which happens very quickly. It is usually associated with an incident of trauma or a severe injury. Some examples of how this condition may rise is surgery that causes blood loss, internal bleeding of the stomach due to an ulcer, a bleeding disorder known as hemophilia, or blood-thinning medications. Some signs and symptoms can include fatigue, fast or irregular heartbeat, shortness of breath, nausea, headaches, and seizures. And in order to diagnose this anemia, blood tests are taken, urine or bowel movement samples are tested for blood, or endoscopy procedure is conducted to check for any internal bleeding. Some other ways to treat this anemia include blood transfusion, fluids or IV fluid that increase blood pressure, iron supplements, and extra oxygen.
All right, on to hemolytic anemia. Hemolytic anemia is another type of normocytic anemia. It's a very common blood disorder which occurs as the body has less red blood cells than normal. The reason for low red blood cell count is because of destruction to the red blood cells rather than the underproduction of RBCs. The bone marrow is unable to produce enough red blood cells with the rate that they are destroying at. There are two predominant forms of hemolytic anemia. One is known as inherited hemolytic anemia, also known as extrinsic hemolytic anemia. This is due to a defect in the red blood cells. The genes that control the red blood cell production suddenly stop functioning the way that they should, and this leads to the destruction of red blood cells early on. Some inherited hemolytic anemia include sickle cell disease, which we will discuss shortly, thalassemia, which we've previously talked on, and red cell membrane disorders, pyruvate kinase deficiency, and glucose 6-phosphate dehydrogenase deficiency. The other subcategory is known as acquired hemolytic anemia, also known as extrinsic hemolytic anemia. which is caused by outside factors, which are uncontrolled by the internal red blood cell, and people are not born with this condition, or not born with that condition. Examples include antibodies from immune disorder, burns, or medications. In this case, the red blood cells are actually healthy when they are produced in the bone marrow. Instead, it's later on where they are destroyed in the bloodstream. Another possibility is if they get trapped and are recycled far too early. This may happen because of certain infections, medicines, one is known as penicillin, blood cancers, tumors, and overreactive spleen. Some acquired hemolytic anemias may include, and forgive me if I butcher a couple of these, immune hemolytic anemia, autoimmune hemolytic anemia, alloimmune hemolytic anemia, drug-induced hemolytic anemia, mechanical hemolytic anemia, paroxysmal nocturnal hemoglobin, it's known as PNH, malaria, and other infectious anemias.
And just a continuation on hemolytic anemia. Hemolysis is a very dangerous occurrence which causes the red blood cells to lyse, and as they burst, they are unable to go through the correct death process. The white blood cells are unable to participate in the breakdown and cannot engulf the cell before it ruptures. This is a massive problem due to the reactive iron which is freely released into circulation. That iron can then interact with tissues and potentially damage them. One example is the kidneys. The kidney attempts to help discrete this reactive iron into the urine, but in the process it interacts with all of the cells of the kidney, and will ultimately damage the kidneys as well. In severe hemolysis, kidney damage and kidney failure are plausible outcomes due to the reactivity of that iron. And on to the symptoms of hemolytic anemia. Some of them include abnormal paleness, dark urine, dizziness, enlarged liver or spleen. And for the treatments, this type of anemia is usually detected by a complete blood count, CBC, which measures the different compartments of blood. Other blood tests can also be used. The urine test is also a way to detect hemoglobin and iron. And lastly, a bone marrow aspiration or biopsy can be utilized. In this test, they either remove a small sample of solid bone marrow tissue or a small sample of bone marrow fluid, and it is checked for the size. Number, maturity of red blood cells, or if there are abnormal cells. Treatments are very specific to the type of hemolytic anemia present and also catered to that specific person, but some common treatments include blood transfusions, corticosteroid medicines, treatment to strengthen the immune system, and in severe cases, treatments include surgery to remove spleen or medicine to reduce the strength of the immune system.
Now we delve into polycythemia. Polycythemia is an overproduction of red blood cells caused by bone marrow abnormalities. This overproduction is caused by a mutation in genes that causes the bone marrow to make too many red blood cells instead of a regulated number of each of the 3 blood cell types: red blood cells, white blood cells, and platelets. The excess of red blood cells increase the thickness of the blood, which slows the flow of blood and causes abnormalities in your platelets, leading to major issues such as blood clots. Blood clots can potentially cause stroke, heart attack, or blockage in lungs artery or a vein in the leg muscle or abdomen. Polycythemia can also lead to enlarged spleen, as discussed in thalassemia. High levels of blood can further complicate, such as causing open sores on the inside of the lining of the stomach, upper intestine, or esophagus, and inflammation of the joints.
All right, so on this slide we have the polycythemia hematocrit. As previously mentioned, the hematocrit is a percentage of blood by volume that is composed of red blood cells. A normal hematocrit ranges from about 38.3% to 48.6% for men and 35.5% to 44% in women. Polycythemia is when these hematocrit levels rise above these normal ranges and is considered when hemoglobin levels are greater than 16.5 grams per liter in women and 15.8 grams per liter in men. Just want to make a quick correction. It is actually 16.5 grams per deciliter in women and 18.5 grams per deciliter in men, which makes much more sense.
So, what's the importance of talking about the hematocrit of polycythemia? The answer is blood doping. Blood doping is an example of artificial polycythemia, which increases the amount of hemoglobin, the oxygen-carrying protein, in the bloodstream. People who blood dope usually do so in attempts to gain a performance advantage. They are essentially trying to make sure that they can compete for longer, especially in endurance sports like cycling, where oxygen-carrying capacity and the blood's ability to deliver oxygen to the tissues becomes a really critical component. Ultimately, when people are blood doping, they artificially increase their hematocrit so that they have more oxygen carrying capacity, trying to become artificially polycythemic. As a result, they will be able to transport and deliver more oxygen to the tissues. 3 types of blood doping include blood transfusions, injections of erythropoietin, which is a hormone released from the kidneys that stimulates production and maturation of red blood cells, injections, and the third is injections of synthetic oxygen carriers. Risks include blood clotting, heart attack, stroke, and spread of infectious diseases from blood doping methods via transfusion.
A popular example of someone who blood doped is Lance Armstrong. Lance Armstrong is a professional road racing cyclist, and he denied for years that he blood doped by beating his test that was performed prior to every race. He was injecting himself with packed red blood cells. In other words, he was giving himself transfusions of mostly red blood cells. He would take the whole blood and centrifuge it as means of separating the red blood cells in order to make it into an injectable liquid. When his hematocrit levels were tested before a race, he would inject himself with saline to increase his amount of plasma volume in order to make his hematocrit appear normal by overloading himself with fluids. These fluids would be expelled through the urine shortly, and he would go back to being polycythemic and have his performance advantage. Some symptoms include that many people who develop polycythemia don't have noticeable symptoms. Many develop very common or vague symptoms, include headache, dizziness, fatigue, or blurred vision. Some other symptoms that haven't been noted include itchiness of the body after a warm shower, feelings of numbness or tickling, burning or weakness in the hands, feet, and legs, bloating, abnormal bleeding, joint swelling, and difficulty with breathing, along with shortness of breath. In rare cases, polycythemia may progress into a form of leukemia known as acute myeloid leukemia. The most common treatment of polycythemia is the frequent withdrawal of blood with the use of a needle, which is also called phlebotomy. This reduces the amount of excess red blood cells. To reduce itching, the serotonin reuptake inhibitors such as paroxetine or fluoxetine may be prescribed. In cases where phlebotomy is not enough, medications can be taken to reduce the number of red blood cells in the bloodstream. Some medications include interferon or busulfan. Medications that control risk factors for heart and blood vessels disease such as high blood pressure, diabetes, and high or low cholesterol. Low dose of aspirin may also be taken to reduce the risk of blood clots and to reduce pain on the hands and feet.
And finally, we have sickle cell anemia and sickle cell disease. We'll get into a couple of their distinctions a little bit later. So first off, we have sickle cell anemia. Sickle cell anemia is characterized by a single point mutation in the beta globin gene. A negatively charged amino acid side chain known as glutamate 6 is mutated into a nonpolar aliphatic side chain to valine 6 in the beta chain of hemoglobin. The new valine side chain can bind to a hydrophobic patch on a different hemoglobin molecule through hydrophobic interactions when hemoglobin is deoxygenated. This causes chains of hemoglobin to form and the red blood cells to become clumped rods called sickled cells. Since the affected red blood cells are now crescent-shaped instead of flexible and round, the cells are prone to clotting, coagulating, and blocking blood vessels, which can further cause complications of blood and oxygen flow. Major complications of sickle cell anemia include stroke, organ damage, blindness, and pulmonary hypertension.
So now to differentiate, we're going to talk about sickle cell disease. This sickle cell mutation that we just talked about also decreases the oxygen carrying capacity of hemoglobin, which is why this disease was termed sickle cell anemia. However, now the term sickle cell disease is used as the complications that arise from the mutation go well beyond anemia. Although anemia itself can be severe, the most severity is encountered when the sickled red blood cells, because of their stickiness, interact more with the walls of the capillaries as they move through. This can lead to blockages of blood flow called vaso-occlusive crisis, which causes severe pain and increases risk of stroke. And on to the symptoms of sickle cell anemia and disease. Symptoms of sickle cell anemia and disease include blood clots, swelling in hands and feet, joint pain, chronic nerve pain, and etc. Though there is no known cure, treatments involve medications or blood transfusions, as well as stem cell transplants, which infuse healthy cells into the body to replace damaged or diseased bone marrow. Management of sickle cell anemia contains medications that overall relieve pain and reduce the need for blood transfusions, such as daily doses of hydroxyurea or prescribed narcotics. And now on to an interactive activity. The goal of this activity is to observe the histology of normal red blood and compare it to the histology of the various types of anemia on the right-hand side. So this is the normal and these are the anemias. Then using the word bank, choose which anemia corresponds to which histology image. So we're just going to give you guys a few seconds or a few minutes to put in your guesses.
You can also go ahead and pause and maybe write it down on a piece of paper.
All right, hopefully that was enough time to take a screenshot or take a picture or pause. And in the next slide, we're just going to go over the answers to see if they were right.
All right, so hopefully you were all able to put in your guesses. So on the top left, we have the sickle cell anemia histology slide. We are able to distinguish it such due to the crescent-shaped cells or the sickle-shaped cells. On the top right, we have microcytic anemia. This one is distinguished by its smaller size and volume when compared to the normal blood histology slide. On the bottom left, we're able to identify it as polycythemia. This is indicated by the overproduction of red blood cells spanning this histology slide. And finally, on the bottom right slide, we are able to identify it as macrocytic anemia. We are able to do so as we detect larger than normal red blood cells. I hope you guys like the game.
All right, and then if you guys have any further questions about what we just discussed, feel free to reach out to any of us. All of our emails are linked below right here. And thank you. We've all hoped that you learned a lot about anemia and disease management, and thank you for sticking through the technical difficulties. And here are some citations. And that is all. Thank you so much.
Thank you.
Thank you.